I would like to welcome you to our Advances in Orthopedics webinar for the RWJBarnabas Health System. My name is Frank Liberace, and I'm the Chairman of Orthopedics at Cooperman-Barnabas Medical Center and Jersey City Medical Center. And I'm happy to introduce and be joined by two of my colleagues throughout the system, Dr. Mark Levine, who leads the charge in orthopedics over at RWJ in Hamilton, who's an esteemed spine surgeon, and Dr. Deirdre Belika, who leads the charge in pediatric orthopedics over at RWJ in New Brunswick at the Children's Hospital. Tonight's panel will be focusing on different aspects of orthopedics based on each one of our subspecialties. And throughout our system and throughout the state of New Jersey, we often collaborate and work with each other to take care of the needs of patients. And throughout the system, we offer all of the subspecialized care of orthopedics to deliver you the best possible orthopedic outcomes. So this evening, since I am a trauma and joint replacement surgeon, dealing with significant fractures and significant joint replacements that have possibly not gone correctly the first time somewhere, or have went well but need maintenance, or have went very well and helped the patient, but the patient sustained an injury. My topic tonight will be discussing how we end up with a joint replacement. And then if it doesn't go as well, or we hit a curveball in life, how do we get out of it, whether it be due to infection or fracture, or just the expiration date of the implant itself. So to begin, many of us are very familiar with the concept of having arthritis. One thing we have to understand is most arthritis is basically due to wear and tear, and how the wear and tear of our environment and our lifestyle and our health and our genetics impact our joints. And we have a degeneration of cartilage, we have some bone changes where we have reactive growth of bone, etc. But there is a secondary type of arthritis, which comes in many flavors, and that's an inflammatory arthritis, which many of you may be familiar with the terms of rheumatoid arthritis, lupus, scleroderma, and there are many other disease processes that fall in this category. In these inflammatory arthritis, it's more than just the mechanical degeneration of the joint, but it's a systemic or total body issue. And with this comes some higher risks than the standard 2% risk of infection, or the standard risks of osteoporosis or weakening bone that some of us experience with age. And some of these challenges really make arthroplasty a life-changing event in a positive way, but something that really has to be acknowledged that there can be issues and complications. So the first thing, even though there are three surgeons here that our favorite thing to do is surgery, is to realize that not everybody needs surgery, or maybe not just yet. And so when somebody presents with a condition, we do have a variety of modalities which can help manage the symptoms and let you maintain your lifestyle for as long as possible. Many of you familiar with, obviously, oral anti-inflammatories, whether over-the-counter or prescription strength, with injections of steroids in combination with other numbing medications. And these steroids do not get absorbed to the systemic or total body system to the same extent as oral or intravenous, yet in diabetic patients and others, we still take heed and are cautious with our injections. But some advancements in our non-operative care outside of physical therapy and some advancements in protocols, which really help maintain lifestyle, are also different types of injections we have, like hyaluronic acid. Hyaluronic acid really helps restore the lubrication of the joint and is a very good alternative to many of the other more antiquated modalities that we use to inject people. And in certain select situations, and we must take caution when, even platelet-rich plasma can be of assistance. And, it is our responsibility to deliver to you the options that make sense for your stage in the disease process of arthritis. If we get to a point where proceeding with surgery will help correct the alignment of your limb, correct the functionality of your limb, your joint motion, and relieve pain, then at that point, focusing on the lower extremity, we have obviously total hip and total knee replacements that are very common. At this point in time, we've really been able to expand our indications with doing hip and knee replacement surgery through the aid of navigation, through the aid of robotic assisted surgery, through the aid of multiple different surgical approaches for the hip, uh, anterior, from the side or lateral, and from the back posterior, or even mini approaches to help restore you to your function in a quicker way. The tenet of any joint replacement surgery for its longevity comes down to the material we use to simulate or replace your cartilage. So there most commonly is some combination of metal surfaces on either side of the joint with either ceramic, metal, or polyethylene, which looks like plastic on the other side to function as your cartilage. And really, we have very good rates of 20, 25-year successes. And the main parts that are in your, let's say, pelvis and femur, femur and tibia, those main metallic parts usually can last the test of time and rarely have issues with loosening, infection, maybe 2% in somebody that doesn't suffer one of the other diseases we mentioned, etc. But it's the polyethylene where we need to proverbially change the tire. If you're fortunate enough for that, you're going to have a great outcome, hopefully, great longevity, etc. But if you do run into a complication, it must be taken seriously. And as with any benefit, there can be a cost. And what's very important is if you as a patient receive a joint replacement, whether one of our facilities or somewhere else, and you feel something is wrong, the best thing you can do is follow up, make calls, and see a practitioner who hopefully either A, deals with such complications, or B, will refer you to the appropriate person that deals with complications in your community. Infection surgery has had many advances for different types of antibacterial and antifungal medications that we can combine with implants to help not only cure your infection if you have one, but to decrease your risk of having an infection the first time around. And so this is very, very important to avoid multiple future surgeries, complications, and decreased function. Now, with the rampant millions of patients that have total joint replacements, even as of 10 years ago, approximately 140,000 people a year sustain what's called a periprosthetic fracture. Such fractures happen around joint replacements and make it quite complicated not only to treat the fracture, but also possibly having to revise the joint because the foundation of bone, which holds your joint replacement, has been affected. We've had many, many advances in minimally invasive surgery, many advances in implants which have been released, which there are designers that have that do work within our system that have helped lead this parade to fixing these problems and allowing for immediate and early mobilization. So all in all, I just wanted to give a brief introduction to really the gamut of treatments available for arthritis and the fact that we respect that you're our patient forever. And if problems arise, there is a lot of advancement going on that help with those problems. So to that point, I'm going to turn the floor over to Dr. Levine, who will discuss minimally invasive spine surgery. And in between, we will be answering via the chat box many of your questions. And at the end, during our Q&A section, we'll try to address all of the others. So thank you for your attention. And Mark, why don't you take it away?
Thanks, Frank, and thanks, Dr. Balika, for being with us today. And of course, thanks to the RWJBarnabas Healthcare System for putting this together for everybody. I am going to share a quick PowerPoint presentation that I put together for this with the hope of covering a large, vast topic in my allotted 10 to 15 minute time frame. So thanks once again. I am part of the orthopedic team for the entire healthcare system. I'm based out of Hamilton, and we have an orthopedic and spine institute here that was established about 18 months ago. And our goal here is to provide comprehensive care under one roof. And certainly the RWJBarnabas healthcare system has a tremendous amount of resources for all of us to draw upon and provide to you. Our offices are actually in the hospital, and with that location, we're able to draw upon the expertise throughout the hospital and the system, including the emergency room, coordinating care and physical therapy, the Department of Radiology. Our operating rooms are just a floor away from us. We can jump down to the emergency room and see patients on the floor with a simple phone call. And of course, all the supporting services that we need in spine surgery and orthopedic surgery are found right here in the hospital, including neurology, vascular surgery, internal medicine, pastoral support when needed, and certainly the academic centers are all within the hospital system. So if you're getting care, whether it's spine or orthopedics in general, as Frank and Deidre will present, this healthcare system is probably the most vast network in the state, and you should feel comfortable knowing that these resources are available at each and every hospital. I myself am based out of the Hamilton division. With that, spine surgery works. 50 years ago, 35 years ago, there may have been some outcomes that perhaps were not as favorable as we see today, and people may have been somewhat intrepid about moving forward with spine surgery when needed. But it's all about the principles. No matter what you're doing in orthopedics, particularly in spine surgery, it's about the principles. And I'd like to kind of share that, good indications are based on having a proper diagnosis. And there's a number of things that have evolved over the years that, particularly in spine surgery, allow us to get what I would say a diagnosis that's much better than perhaps we were able to get with the improved resources today that we had in the past. And if you add that with good surgery done well, and in this context, we'll kind of touch upon some of the newer techniques being minimally invasive surgery, as well as the improvement of implants in spine surgery, you're going to get good outcomes. And what good outcomes allow us to do at this point is get patients mobilized earlier, perhaps in a same-day environment, but certainly a shorter hospital environment. So let's start with the evolution of spine imaging. And I think this is probably one of the keys within my world in getting a proper diagnosis. And what I've set up over here is simply a schematic of the lumbar spine, which I think is probably most common to people to understand. This schematic shows that we do have 5 bones in the low back. This is 1, 2, 3, 4, and 5. And between each block of bone, we have a disc. And that's kind of what we call a motion segment. A bone, disc, bone is a motion segment. So, early on, we had plain x-rays, and that's what this picture to the immediate right of the schematic shows you. And on an x-ray, you can generally see the alignment of the spine. And once again, this is a block of bone, this is a disc, and this is a block of bone. The belly's over here, and this is mimicking the schematic that you see to the left. And the one thing you can pick up on this picture alone is that this block of bone has slid forward ever so slightly on this block of bone. And here's the front of the block of bone here, and here's the front of the block of bone here. So this is a simple x-ray, and that's all we had probably 35, 40 years ago to use in diagnostic purposes. The next thing that probably came into play for us from a diagnostic standpoint in the evolution of imaging was a CAT scan. A CAT scan is a computerized tomography, and it gives excellent bony anatomy, whether it's of the spine, a joint, or a hand. And this is probably the next thing that helped us better diagnose and get a better treatment plan for people with spine problems. And over here, this is a block of bone here, again, mimicking the x-ray and mimicking the schematic. Here's a block of bone, a disc space, a block of bone, and a disc space. And what I did here is I actually took a further evolution of spine imaging and showed you what it looks like when you inject a disc with a contrast dye to try to better diagnose if someone has a degenerative problem of a disc. And the first 3 discs here, you can see how the dye is well contained in the disc space. And in this space here, it's leached out. It's leaked out because there's a problem with the disc space itself. So we've gone from a schematic to an x-ray to a CT scan from the side, which is a 3-dimensional reconstruction. Then we added some dye to the disc space. And now we have the ultimate study that we have today that's really changed, I think, a lot of our ability to diagnose quickly and adequately spine pathology. And this is an MRI scan. Same orientation as you see from the 2 previous studies, with the belly being in the front, the back over here. And here's actually the spinal cord coming down right over here. And it evolves into something called the cauda equina. And then over here, I showed you a disc herniation. So here's bone, here's disc, here's bone. And at this level here, this is bone, and here's a disc pushing back into the canal. So you don't have to be a fellowship trained spine surgeon, as I am, to see what a disc herniation looks like in an MRI scan. It's pretty well illustrated for you right there without much effort. So that's kind of the general imaging that we do in spine surgery. And I think that gets us part one of what we need, which is a good diagnosis. Now, a lot has been said as to minimally invasive spine surgery and the benefits. And I think the literature, if you look at the literature, which we do for you, will bear out that minimally invasive spine surgery has major benefits from open traditional surgery when possible. Not all surgical pathologies are amenable to minimally invasive techniques, but they are certainly growing. And we're certainly able to do more and more today. The benefits are fairly clear cut. It's less blood loss, which means less transfusions. There's less pain requirements, both during the hospital stay as well as on discharge. And probably one of the most important things that I look at is it's much less muscle dissection. And I think a lot of the people that have had chronic back pain after extensive spine reconstructions in the past, we've been able to see that a lot of it has to do to the muscle scarring that goes on, which is largely improved with minimally invasive spine surgery. There's clearly a faster return to activity, shorter hospitalizations, and maybe not important to you, but important to me, and I'm sure Frank can attest, and Deidre, there's less physician wear and tear with minimally invasive techniques largely because of the instruments that we use that are much less aggressive and I would say much more refined. But again, it depends upon the pathology. Not all pathologies are amenable to minimally invasive spine surgery, and you certainly need to discuss this with your surgeon to find out if you're really a candidate for that. So how has minimally invasive spine surgery evolved over the years? Well, I think probably the number one technique that has really kind of introduced it to many spine surgeons, I've been doing this for over 20 years, and probably the first technique that was utilized to create minimally invasive techniques had to do with managing compression fractures. And this picture to the far left is showing you a compressed vertebral body over here. That's a normal bone above and a normal bone below. And what I've kind of shown you here is how we address this in a minimally invasive technique now, where instead of making any big incisions, we make an incision in the back about the size of a pinky, put something that looks like a straw into the bone using X-ray guidance. This is a balloon which would get inflated. Once inflated, it would increase the distance between the end plates, and then you would fill that void with bone cement. But that's probably the technique that many spine surgeons today first got introduced to in creating minimally invasive techniques. That has gone now to endoscopic repair, where we actually use scopes and make small incisions, just like someone may have if someone's familiar with a knee arthroscopy, we're able to do things with scopes and endoscopic procedures. We use special retractors that really keep the incision very small and allow us adequate visualization to do what we need. And now we're evolving to robots in the operating room, which are also assisting with minimally invasive techniques. And not shown here is artificial intelligence, which is also adding to our ability to treat and manage patients with minimally invasive techniques efficiently. So, good outcomes. We kind of put together a good diagnosis, a good surgery, now good outcomes. The patient on the left, I should say, has these two small incisions, which we did a fusion through. And the patient on the right has an extended midline incision and a graft site, kind of showing, the differences in a very dramatic way between some of the minimally invasive techniques and the traditional open techniques. A lot of these techniques that we showed over here also rely upon implants. And the world of implants in spine surgery has evolved tremendously over the past 20, 25 years. We have different implants that we use to put between the vertebral bodies that have evolved, and some of them are dynamic, meaning they change with pressure. We have implants that are designed to be screws to put in the back of the spine. And now we have all different types of biologics that help enhance a fusion, which means that oftentimes we can avoid harvesting bone graft from your body by using other substitutes that give adequate and equal bone fusion rates. So at the end of the day, again, this is kind of a quick tour through minimally invasive spine surgery, but it's all about the principles. You can have a diagnosis that can be treated several different ways. I do feel that our visualization of the spine now gives us a good diagnosis. I think that the evolution of minimally invasive techniques and improved implants further adds to the success of minimally invasive spine surgery, both in the cervical spine, the lumbar spine, and the thoracic spine. I think we're clearly seeing better outcomes with early mobilization, same-day surgery, and outpatient patient satisfaction long-term. And these techniques and technologies are all available through the RWJBarnabas healthcare system. I think our spine surgeons that we meet with on a quarterly basis are all in sync in how we are able to provide this top-level care seen in our state at all the hospital systems. And I would encourage you, if you're having back pain, if you've had sciatica or pain shooting down your leg, and these symptoms have not responded to non-operative treatment, which we all should try before surgery, consider spine surgery, because I think you'll find that the world of spine surgery today has evolved tremendously from the way it was 25, 30 years ago. So I'd like to thank the Barnabas Healthcare System and Frank for allowing me to participate with today's webinar. And I look forward to questions as needed moving on with today's program. Thank you very much.
Well, Mark, that was great, and thank you. The chat box is open to everybody, as mentioned, and we'll answer chats as we go along, but certainly at the Q&A section, we'll try to hit all the high points. And it's really good to see just the way we've gone to same-day surgery and maybe at max one evening for total joints. It's great to see that in spine progress as well. So thank you very much, Mark. And Deirdre, why don't you teach us about how to address the malunited fracture in the pediatric patient?
Thank you. I just want to thank Barnabas for having us here and the other doctors for taking the time out of their schedules to talk. If anyone has questions, please feel free to put it in the chat box. Just a little bit about me. I'll try not to talk too fast, but I am from New Jersey, so probably not going to happen. I'm Deirdre Balicka. I'm a pediatric hand and upper extremity surgeon at Robert Wood Johnson Barnabas. So I trained actually at Rutgers Robert Wood Johnson for residency, and then did hand and upper extremity fellowship in Pittsburgh, followed by a second fellowship to specialize in taking care of the upper extremity or the arm in children in California before coming back to the system. So I have kind of a pretty unique specialty in that sense, in that I can take care of both kids and adults, although currently my practice stops at 26. So I tried to pick a topic that I thought would be relevant to everyone, although it's a little daunting to talk about fractures with Dr. Liberace here because he's an expert in them. But when we look at kids with fractures, the chances of having a fracture as a kid is somewhere between 12 to 30 per 1,000 kids. Or to put it another way, between birth and the age of 16, you have up to around a 62% chance of having a fracture in general. And, you know, when everything goes well in kids, what do? Is we see the fracture, we line it up appropriately, and then immobilize it there, usually in a cast for most kids. And for children, we get away with a little bit of things not having to be perfect, because as kids grow, they can actually remodel a little bit of imperfection. How much depends on the amount that it's already not perfect and the age of the child and where exactly the fracture is. So one of the things I wanted to focus on is not when everything goes right, but when everything doesn't go right. And this is a problem that I personally saw become a little more severe around COVID. In the case I'm going to kind of show you guys to just give some visual representation, we'll kind of explain how that is. So during COVID, a lot of people would injure themselves and not come in and seek care initially because they were nervous about the virus itself. And so I ended up seeing a lot of late fractures. And I'm just going to share my screen to kind of give an example of this and then go through some of the new things we can do to fix this problem if it happens. So let me just share. Okay. Can you guys see my screen okay? I think so. All right. So this is a 12-year-old girl who actually didn't present to me initially. She kind of came in to another physician a month after her injury. Again, she delayed coming in because they were nervous about seeing a healthcare provider during the pandemic. And what she has going on is a fracture of her wrist. So just a little bit of very quick anatomy. This this line right here on this portion is normal because it's her growth plate. So she's still growing. You see that on the side view also. What we should see is a straight line coming across here, but we don't because there's a fracture right here and it's pushed down. It's a little bit harder to see that fracture just because it's already about a month old and already starting to heal. When they saw the other provider contacted me and we got them in for an appointment, but unfortunately the patient themselves came down with COVID and they ended up not seeing me for about a month afterwards. Um, and so by the time they saw me, they were about 2.5 months after their injury, and their fracture, which again, you should see a nice straight line here, had already healed in this kind of depressed position. And to just kind of see the fracture a little more, we did get some advanced imaging, which we just had a nice talk about, CAT scans and MRIs, but this kind of helps show this piece of bone being pushed down right here. And I think this is a really hard problem to fix because this fracture involves a joint too. So we know it has to be perfect. We know that this is not one of those instances where with time it's going to get better or line up better or remodel as you would. And it's also a very technically difficult fracture to fix because it's hard to see all the points where you need to afterwards to get it lined up. So one of the things that I've started to do more for this type of malunited fracture is we'll actually get these CAT scans of both sides of the limb. And then we do digitally 3D reconstructions of them and actually plan out where we're going to perform our osteotomy visually through a digital platform first. I personally use a company called Materialize. I have no financial ties to them. It's just the company I was trained to use. So this is kind of some pictures of us going through how we would cut this bone to then be able to shift it back into its more normal position. And this is us actually doing that digitally, showing how that piece would slide. And when you do this, you can have measurements between certain parts of the bone and where things are going to be so that you can replicate this intraoperatively. And then when we continue on, they'll actually then create patient-specific guides that will guide us during that surgery, just like it kind of sounds like, to then perform the surgery and perform the osteotomy exactly how it was planned preoperatively during that digital session. And this is kind of just some pictures of that surgery, us doing that osteotomy. You can actually see off to the left a little guide that was created also just so we could model it and make sure everything kind of looked appropriate. And then this is us fixing the bone into that position with the plate afterwards. And these are kind of her x-rays about a month or so out from that surgery. Unfortunately, she's kind of, sorry, this is the month out. So fortunately, she's gone on to heal just fine. And everything ended up pretty good for her in terms of that. But I think that this is a really interesting advancement in orthopedics, being able to do these surgeries digitally. I don't think every fracture needs this per se, but I think that it's interesting when you have an intra-articular fracture to be able to plan it more precisely and make sure that you're lining everything back up perfectly. So that's kind of everything I have for you guys. If there's any questions, please let me know.
Thank you, Deirdre, and that's also very good. And I think as we all have been discussing tonight, we realize that the advancements with our field, with robotics, being able to address certain parts of joints, doing minimally invasive surgery, and really being able to deliver less surgical trauma to the patient to help fix some of the traumas of life and get them back on the train is really pleasing to see throughout. So that's really great, and I'm glad we had this time. A couple of the questions that came through our chat room, one of them was, is it safe to get knee replacements done at the same time on both sides? And the answer is yes, at many times. But we really study a lot of factors that go into this. The person's general health status, how we think they'll be able to respond to therapy, even though we have a ton of advancements with how we manage pain with blocks, where people have nearly minimal to no symptoms after surgery, or long-acting medications that we implant during the time of surgery, and pre and post-operative oral medication protocols that complement and enhance the benefits and decrease narcotic usage. It still is a recovery period that happens. So we take that into consideration based on the person, also their health status and how much we think they could tolerate, because the last thing we want is to enhance risk. Overall, we do this on many patients with great outcomes. Recovery is a touch longer than doing one side, but still it also saves recovering from having both sides done in a staged fashion. So it's definitely a very personalized approach that needs to be done with your surgeon, and really be full disclosure about your medical history, because it helps with what I think we all exhibit, regardless of our specialty, is shared decision making. Um, there was one more question relative to knee prior to us getting to spine. And it is, with knee surgery, when there's bowing of the knees due to arthritis, how is one knee replacement handled? Well, that is a great question. So, part of the goal when we are doing a resurfacing of a joint, we call it replacement, whether it's partial or full, whether it's knee or hip or shoulder or elbow. But the main goal is pain relief. But to help accomplish that pain relief and help allow for appropriate longevity of the implants that we put in, so the couple of decades or more that we want out of those implants, it's important we restore your alignment. That's our responsibility. So if you come in with significant deformity, our goal is to help eliminate that deformity and make you within the bell curve of shape, alignment, and angles that can help with the best wear rates, and to give you as much symmetry as possible to make your gait as normal and pain-free and functional as possible, as well as if you return to sporting activities and everything else. So it is part of the deal, making your limbs straight and resurfacing the edges. Another question came through relative to if somebody has spinal implants in for many decades, is there a necessity to remove them? And also, if in the setting of having some chronic low back pain. So, Mark, if you could tackle that for us, that'd be great.
Sure. Thanks, Frank. So the question really brings out 2 points of interest. Number one, if you've had a previous lumbar fusion or cervical fusion, implants do not generally come out unless there's a problem. So they're made to stay there forever. What's interesting is that in the world of spine fusions, whether it be lumbar or cervical or thoracic, this one refers to lumbar, the instrumentation is really there to provide a scaffold until the fusion takes. So, there's 2 parts to having instrumentation put into your body, particularly in the spine. One is provide immediate stability for your spine. The other is really to allow the spine to remain in a stable position until the fusion takes. So the analogy I often give my patients is that if you think about concrete being poured for a sidewalk, you'll often see rebarb put down, and then the cement will be spread over the rebarb. And that's kind of, it's not a perfect analogy, but I think it kind of brings to light the concept that, when we do a fusion, we're depending upon that instrumentation, not necessarily forever, but until that bone graft, whatever material we put in there to get solidly fused, then takes a lot of the stress off the hardware, which doesn't have a infinitum expectancy of sharing load. So to answer the question, number one, you don't expect to take out the hardware unless there's a problem. The second part of the question is what's going on above and below the fusion, because this individual's question seems to bring to light the possibility of developing pain down the road. In this case, it appears that they had the fusion 30 years ago, and now they're starting to have pain perhaps below where the fusion ended. And that's not uncommon. And, the way to think about it perhaps is if you have a bicycle chain and 1 or 2 links are no longer moving, to go around, the links adjacent to the links that aren't moving have to work overtime. So when you have a lumbar fusion, you're taking away motion, and therefore the levels above and below are working overtime to achieve motion, and therefore can wear down over time. And that can cause a source of pain, and there's ways of treating that non-operative to start. But what's exciting is now with a lot of these new minimally invasive techniques and different accesses, you can often take care of the adjacent level or the level that we call above or below the fusion without making a big midline incision and coming at it from different parts of the body without disrupting muscle and without disrupting the instrumentation. So number one, instrumentation does not need to come out unless there's a problem. Number two, not uncommon to get pain above and below a previous fusion. And lastly, there's ways of addressing that pain if needed surgically that weren't available 20 years ago that can access and use minimally invasive techniques and technology consistent with minimally invasive spine surgery.
Great. Well, thank you, Mark. So on that note, I really would like to thank obviously all of our surgeons that joined the program. I certainly want to thank all of you that have joined for this informational session, and really want to extend the offering to all of you and your families and friends for our RWJBH healthcare family, and for orthopedics, because we really are leading the charge in the state and using the most current technologies, and we're here to serve you. So thank you, Mark. Thank you, Deidre, and thank you, everybody, for joining.
Pleasure.
Have a good night.